Good afternoon, everyone. We will be starting in a couple of minutes, but in the meantime, our speaker has asked to show a question. It's a pre-conference question. So please look at the slide and just think about what you would answer. And we'll get started in just about a minute or two.
Hey, Kamal, how you doing?
Hey, Dominic.
Okay.
Glad it worked out with your lumbar puncture.
It did. We just got it, residence done, so perfect.
Okay, wonderful. So we're going to give the audience a minute to look at your question, Dominic, and then I'll start your introduction, okay?
Sure, thank you.
Great. Okay, good afternoon, everyone. Before I introduce today's speaker, I have a few housekeeping items to take care of. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find the evaluations by following the link in the chat at the end of this talk or at any time on our website and email advertisement. Your comments are very important to the planning committee and will be used for future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers will disclose any real or apparent conflicts of interest. Dr. Chow has disclosed that he has no relationship with commercial supporters that could be perceived as a conflict of interest. It's my great pleasure to introduce our speaker, Dr. Dominic Chow. He's a professor in the departments of medicine and pediatrics at the John A. Burns School of Medicine. He's also the medical director of the Clint Spencer Immunology Clinic and a co-investigator at the Hawaii Center for AIDS. He's an attending physician at Kapiolani Medical Center and the Queen Emma Clinics, where he helps to train pediatrics and internal medicine residents. He has won many awards for clinical service and teaching. I'll just give you a few highlights. The 2014 Suzanne Richmond Crum Award for Outstanding HIV/AIDS Services in Hawaii, given by the Department of Health. The Schwartz Center Compassionate Caregiver Honorable Mention Award in the years 2015 and 2016. Best Doctors in America continuously from 2011 to 2020, Best Doctors in Hawaii from 2008 to 2014, and the 2014 Chancellor's Citation for Meritorious Teaching. This is just some of his awards. So we are so happy that Dominic has agreed to talk to us today on the very important topic of long COVID. Take it away, Dominic.
Thank you so much. So do I have the cursor or do I just say next slide? I don't know if how Julie made it. Oh, John?
Yes, you can just go next slide and I'll progress it for you.
Thank you. So next slide. So the question that was for the pre-conference questions, as you saw, and you had a chance, you could see that the answer was C. People who are vaccinated after their diagnosis or less likely to report symptoms of long COVID compared to people who remain unvaccinated. So even for those individuals who have gotten or currently in your practice who just got COVID infection, you would want to actually advocate to try to get them vaccinated as soon as possible. And yet another reason for vaccination at this time period. So other questions or other answers or basically you could reread that my slides will be available for everybody, but perhaps I could go on to the next slide and begin the conference discussion. So again, thank you all for the Department of Geriatrics for giving me this opportunity to talk about something that I think will have a significant impact on your practice and for the future. I just read in the Lancet about how long COVID will affect or increase the risk for cardiovascular disease within the next 10 years. And that was also true for the risk of dementia. how these investigators from Harvard and as well as other medical centers have determined that it's kind of unclear, but as far as looking at all the biomarkers and the symptoms and overall clinical outcomes of patients, they do foresee that there's going to be a large wave of these complications that reflect neurologic, pulmonary, psychiatric conditions because of the pandemic. So next slide. Next slide. So my objectives today will be to talk about long COVID. It is officially named post-acute sequelae of SARS-CoV-19 or PASC, but we commonly refer to it as long COVID. And then for you to appreciate the symptoms and signs, the signs and symptoms specific to pulmonary, cardiac, neurologic, and psychiatric complications, and to try to understand some of the pathophysiologic mechanisms in a way of trying to develop ways of actually combating and treating this long COVID. And then finally, as I mentioned, recognizing the potential treatments today and potentially for the future. So next slide. It's been a little over 2 years. I know it's, for many of us, it feels like almost a lifetime of how COVID has affected our lives. If you look at just in January 11th, the first reported death in China, and then subsequently on March 6th of 2020, Hawaii first got its first cases of COVID-19 on a cruise to Mexico on a Grand Princess ship line. And then closer towards November 24th of last year, we saw the first cases of Omicron. And then on a brighter spot, recently, Hawaii has 77% fully vaccinated and 84% at least one dose. But if you think about how COVID has affected the population, you could see that the US population, there are 79 million individuals who have been affected. The number of deaths is almost approaching 1 million. And the new cases has actually fallen as the cases has dropped recently, but it was quite high during the Omicron outbreak. Here in Hawaii, a quarter of the population has been affected by COVID. And so 1 out of 4 people have been affected by COVID. If that sinks into your brain as far as, wow, that's a fair number of individuals who have gotten clinically diagnosed with and actually tested for COVID. It may actually be higher. Next slide. And you can see that the surge of obviously the Omicron was the most recently, was the 5th surge. And you may be hearing that the new variant, the BA2, is now upon us, and perhaps that might also cause another spike. Hopefully not, but next slide. It does affect people of color. Here in Hawaii, you could see that the green shows the number of infections, and the brown is the state population. I'm sorry, the gray is the state population. And you can see that the Filipino one in the center, as well as the Pacific Islanders, are disproportionately affected compared to all other populations. Next slide. You can see among our patients in the Queen Emma clinics, you could see that it's primarily Chukchukis, the people of Micronesia, and the Filipinos are the ones that are disproportionately affected in our clinic. Next slide. And we have had a health disparities, and it is COVID has shown that the safety nets that we've seen traditionally capture or protect our patients has now been eroded, and many people of color are disproportionately affected by COVID. The Native Hawaiian Pacific Islanders, you could see, is higher in the case per 100,000 people, the number of hospitalizations, and the number of deaths. You could see a profoundly higher among our patients compared to the general population. Among individuals who are Asian, you could see in your graph in red, you could see it's primarily the Filipinos. And so just to show that Filipinos and people who are Pacific Islanders are disproportionately affected by the SARS-CoV-2 infection. So next slide. It's just a shout out to some of the individuals working in the Department of Medicine, Health, and I know in geriatrics too. We all look at these social determinants of health, and as I mentioned before, really a lot of the safety networks have been eroded with this pandemic, and it isn't just the infection, but you could see that there are so many factors that go into complications with COVID infection and also how we deal with it. So housing, food security, social income, social isolation, all of these things go in a whole. And I do appreciate the individuals who are working towards looking initially at the social determinants and trying to figure out ways where we could actually help individuals kind of with not only with long COVID, but also with acute COVID too. So there is my colleagues at the H4RC, the Health Harm Reduction Center, talking about housing and how housing is just as important as medicine. And so there's a lot of data that shows that housing is an important factor in trying to combat disease. Next slide, please. You can see that the epidemic is upon us. Obviously, I mentioned a quarter of the population has been affected by the COVID, the SARS-CoV-2. But I do not know if you are aware that up to a third, maybe even higher, of all COVID infections will actually have long COVID. So I think that the recent estimates that I saw in the New York Times was a third of all individuals. The duration is unknown, possibly permanent, and there's a high degree of disability. And you can just see celebrities. I just have it here. There's Alyssa Milano, and you could see about how her oxygen. Lena Dern had swollen hands and feet and increasing migraine headaches. And then there's individuals like our senator, State Senator Kalani, who basically reported having brain fog to the point that he couldn't function and had to resign from his legislative duties. Next slide. So this is a little profound in that there were mentions of more than 100 million people worldwide have or had long COVID studies. And really, if it's a third of all COVID cases, you could see how these people, these news people would maybe hype this up. I'm not sure how high this number is. Several infectious disease friends of mine have all debated about how real this is. If you take it as far as 20,000 possible people in Hawaii having long COVID, you could see such the magnitude of such a condition. Next slide. So this cartoon basically shows you the circles represent the frequency and basically the position of where long COVID is. So neurologic, neurocognitive, neuropsychiatric, upper respiratory, cardiac, dizziness. A lot of people have talked about POTS, which is postural orthostatic tachycardial syndrome, or POTS. It's been retermed as being a post-COVID tachycardia syndrome. And you can see fatigue is a big circle, as well as systemic fever and weakness, gastrointestinal and musculoskeletal. All of these things, by far the top are fatigue, shortness of breath, anxiety, and concentration, cognitive changes. And I think the Department of Geriatrics is really would be at the front edge, primarily because you guys know about how to do neurocognitive testing. A lot of other departments are unaware, even within my Department of Medicine, the comfort level of doing neurocognitive testing, doing frailty testing is not really common in our primary care practice, although it is becoming more and more common as time goes by. Next slide. And so you could see that from this one, that there's a nasopharyngeal viral transcripts can be still recovered in the nasal nares even after the acute phase of 1 to 2 weeks. So the curve of the red shows the viral recovery from the respiratory tract, but the nasopharyngeal, you could see that you could still get transcripts. And on top, you could see acute COVID and then post-COVID. And among post-COVID, you could see there's subacute or ongoing that occurs from after week 4 all the way out to week 12. But after week 12 and onwards, we do consider that chronic post-COVID or COVID-19. And you can see, again, all the symptoms that go in kind of in the findings of this. The nasopharyngeal transcripts, our group has been collecting nasopharyngeal swabs, and we do know that certain individuals do continue to shed virus. We were previously didn't think that the coronaviruses led to reservoirs or latency, because we thought that once you get this common cold, that you'd be one and done. But we now know that for certain populations, particularly HIV patients, people who are immunocompromised, that they can actually shed nasopharyngeal transcripts, viral particle basically, for a much longer time period. Next slide. And then the WHO, this couple of weeks ago, led its case definition. The next slide. And you could see that it's somewhat vague. It's a history of probable or confirmed SARS-CoV, usually 3 months from the onset of COVID-19, with symptoms lasting more than 2 months and cannot be explained by alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but others generally impacting everyday function. Symptoms may be onset and recover and persist from initial illnesses. And then these symptoms may fluctuate and relapse with time. And the CDC definition, very similar in its findings. Typically, it's 4 weeks out. That's what we use in our clinic, 4 weeks from acute COVID. And if you're still having lingering symptoms, you would be considered long COVID. Whether or not it's subacute or chronic needs to be further defined by the clinician. Next slide. And you can see that it can occur in the very critical patients who have been in the ICU, or the asymptomatic ones. And it's all with this post-COVID acute diagnosis. For children and adults, their manifestations can be a little different. For children, more likely to have this multi-organ or multi-system inflammatory syndrome. Adults tend to have other manifestations, although immunologically there is a pattern coming out. Next slide. So the pathophysiology of organ injury for acute COVID is this cartoon that we see. You can see that the virus, everyone now is able to recognize that there's SARS-CoV-2. It attaches to the ACE2 receptor and the TMPRSS receptor 2. With that combination, it actually can cause direct cytotoxic effect, or it could actually have a dysregulation in the renin-angiotensin system, which our group is actively looking at, primarily because this creates a dysregulation of the immune system as well as blood pressure. Some of the symptoms that people have been reporting about, like dizziness and such. You can see that there's endothelial direct cell damage, and then finally there's endotheliitis, and then immune dysregulation, which a lot of people are looking at, like, is it a monocyte issue or a T cell issue? That still needs to be defined. But IL-6 and D-dimer, those tend to be a lot of, I've heard about both of these involved with like frailty in the elderly population, and this isn't uncommon for IL-6 and TNF-alpha. Next slide. And so the potential mechanisms are further direct towards long COVID. The previous slide was acute COVID. Autoantibodies, you probably have heard about how these antibodies that your body produces can be directed towards like the ACE2 receptor. And that's what we've been trying to look and see if that might be potentially the issue. So autoantibodies potentially may be higher among people of Polynesian and Asian descent, in where Sandy Chang with the Department of Tropical Medicine is kind of looking at those differences in groups and perhaps maybe teasing out long COVID. The next one is that of post-viral transcripts. Recall that the nasopharyngeal area, you could receive or recover viral particles. The reservoir is the next one that is potentially possible. Something that we are working on is monocyte activation. We have a recent paper coming out that looks at activated types of monocytes and how it's related to lung function that our group has reported. Inflammation, that's all all-encompassing term. It could possibly be from IL-6, TNF-alpha. Many people have reported about inflammation, how hyperinflammatory conditions are occurring in people with long COVID. But a direct cytokine has not been linked yet. But I think probably IL-6 and maybe IL-3 is a potential candidate. Vascular injury, such as microclots, have been reported, and I'm going to report on something called the Stimulate trial that showed that perhaps by giving antiplatelet therapy, maybe antifibrotic therapy, maybe the symptoms are reduced. Biosenescence or weakening of the immune system, especially as you get advanced age, will actually allow for other viruses to come out. So you may have heard about CMV, Epstein-Barr suddenly coming into play with long COVID. I personally don't think it's these viruses are the ones that are causing long COVID, but I think our immune systems are being weakened to the point that it allows for these viruses that are dormant in our body to suddenly kind of emerge. And then there's mitochondrial damage with immunosenescence. And so you may have also heard about mitochondrial issues. And someone, investigator, Mariana Gershenson, does a lot of our mitochondrial assays, and we're kind of active in looking about this damage. Next slide. And then cardiovascular complications, probably it's actually been less of an incident compared to when we initially started seeing acute COVID patients. Recall that when COVID first began and it started affecting college campuses, there were a lot of football players that had gotten COVID. And then the next slide will show that these patients through cardiac MRI will have some reported injury or lighting up on cardiac MRI. And it's a fair number, almost 50% of all those individuals who were athletes, some having symptoms, some not having symptoms, will actually show myocarditis and cardiac injury. But the good news is that they did do a follow-up of all these athletes, and by 9 months, all the changes that has occurred with cardiac MRI, to my understanding, has all resolved, probably because these individuals were pretty fit to begin with. Not sure about the elderly population and how their cardiac MRIs would whether or not these symptoms would persist. Next slide. And so cardiac pulmonary sequelae, not uncommon. You could see 83% had shown opacities. And then there was more frequent consolidation in 41%. And these were individuals in the cruise line that I mentioned initially. These individuals all were altruistic and participated in the study, and they did CT scans on these individuals with time. But you could see that a lot of these individuals, more than 50%, will have issues with the lung. And that's not unlike from our data. We also have been seeing that a lot of individuals who have had COVID will continue to have some sequelae of lung effects. Next slide. So neurologic complications, the reports of headaches, seizures, ischemic strokes have been reported. Really the cognitive dysfunction really is the one that really stands out, along with olfactory and gustatory dysfunction. So lack of taste, loss of smell are the ones that seem to get most high attention. And I know that there are some reports of structural changes on MRI, DTI, but there seems to be overall, a lot of these patients have normal structures. I think the next big step is going to be functional MRI, and then also some of the reports from Queens, at least, maybe it's not only arterial, but venous supply as being venous congestion that may be causing some of this brain fog that patients are getting. So next slide. And in psychiatric conditions, bipolar, we've seen a lot of anxiety, depression, fatigue, post-traumatic stress, primarily for those who have been hospitalized, and then executive syndrome or the brain fog. And I have to say, in our clinic, we have an instrument to look at anxiety, and then also one for depression. So we are seeing that anxiety is a little bit more pronounced than just depression. So it's not a combination of the two, but we are indeed seeing anxiety being solely as one of the issues with psychiatric complications of long COVID. Next slide. Thromboembolic complications are very common. Pulmonary embolism, 20 to 30% in individuals who are hospitalized. And then I think we're doing a much better job in the hospital in giving patients, heparin early on so that they don't develop these, lifelong traumatic blood clots. Next slide. So for the long COVID in primary care, I think it was a nice article in BMJ, and you could see that the focus on the person as a whole, there's medical management and self-management, and then there's basically getting referrals to subspecialty care, and then also what we could do as primary care physicians. So up on top on the green, you'll see that they have things like C-reactive dimer, C-reactive protein, D-dimer, ferritin, chest X-ray, EKG. I think Dr. Bello, who's infectious disease, as many of you know, here at Queens will always tell me, we gotta always talk to the patient, get a really good history, get a good physical, and always get a chest X-ray and EKG. And I really do think that really tries to answer some of the questions, and getting a history, oftentimes we find that patients will have lots of complications even before the COVID complication, and that COVID just brought it out we're seeing some of the, perhaps augmentation of COVID on these chronic diseases. You can see that blood pressure, respiratory, getting again a good history, trying to actually look at patients as a whole, trying to get them to be go for physical therapy and doing self-specialty care, and also trying to be a safety net for your patients, trying to advocate for them, trying to get them disability if they are disabled, because it can have a profound effect on overall their financial future. Next slide. Oh, and so in some of our long COVID patients, you can see we ourselves have shown very similar these elevated biomarkers, C-reactive protein, and also ferritin in some of these patients. Oftentimes, I don't know what to do with these biomarkers. I know I'm obtaining it. I could see the trend and whether these patients are actually getting better towards the baseline, but I do have patients who have very high elevations of ferritin that I just sometimes just get, and I'm just seeing it go down, but it has been continually elevated. I'm not particularly sure what to do with those numbers, but I am collecting that. If you guys have any suggestions as far as biomarkers, I'd love to hear it. And I think geriatrics department, you guys do a lot more things in terms like, I think one of the first departments should look at like C-reactive protein and cardiac function. I mean, those are kind of the cutting edge of where research and regular standard of care is kind of meeting its goal, and in trying to see where we could actually help patients by, again, antiplatelet therapy, early statin therapy, or trying to look at glucose metabolism, maybe start people on diabetic medications earlier, as we know these metabolic derangements occur in a much accelerated fashion in long COVID. So next slide. So post-COVID care really is really focused on looking at shortness of breath, hematologic, neuropsych, and renal, and then primary care is, again, early rehab, clinical research studies and such. So next slide. This was just a continuation of the BMJ article, and you could just see that there's all these investigations we do. Next slide. And you could see mental health is very important in providing a safety net and really being an advocate for your patients. I've seen so many of our post-COVID care patients here where they'll say no one believes them. they feel isolated, and that isolation itself can be quite traumatic. So patients will say that their family don't believe that they're really sick, and then also their clinicians, their primary care physicians, will often say, I've done all these things, I don't see anything, and kind of shoo them away. We don't have the right tests right now to really kind of help our patients and really make a diagnosis for a lot of things. Brain fog and cognitive dysfunction is a major issue, but I think it's going to come. It's coming around. I think more and more tools are being made, and we will start to know more about long COVID as time progresses. Next slide. And so you can see that the Queen's medical care, we really have four this paradigm is four focuses: clinical, which is the post-COVID care clinic, but research, we do have a Angus Foundation grant that's looking at some of these biomarkers and looking at prognostic and looking at the mechanisms of long COVID. Education, doing CMEs, and also getting out to the population that this is indeed a real condition. And then occupation and student health services is also available. When to go back adequately to go back to work, and then when to go back to school, when to participate in sports is big things. Next slide. And then we did have these COVID studies. And oops, sorry, go back. Okay, so this one showed that a patient coming to our clinic, they'll get registered, they'll do we used to do the Hamilton questionnaire for anxiety and the Beck's for depression, but they were cumbersome and right along. So we kind of streamlined it just for the general anxiety, depressions, disorder questionnaires. We have our own COVID questionnaires, really looking at where they live and what maybe risk factors, smoking, diabetes, things of that nature. Also race, ethnicity is in the questionnaire. Employment, and also multi-generational household, we ask those questions. We do the physical activity questionnaires. We do the MOCA because it seems to be the most sensitive, the Montreal Cognitive Assessment. We do look at frailty questionnaire, and then physical exam. We do the NIH stroke scale, and then we do vibratory DTRs and strength in a 6-minute walk. Next slide. And then based on that, we would then go on to do a chest X-ray, PFTs, EKG, echo, depending on the symptoms that patients have. And then we always get some blood work, CBC, CAM. We do antibody quantification just to verify that they do have long COVID. We often would ask for the positive test, but if it was self-identified or a home test, we do the antibody looking at primarily spike protein just to confirm that they did have a COVID exposure. We do some inflammatory markers, troponin, thrombotic markers. Next slide. And so our treatment, there are no clinical guidelines available yet. We may provide insight into complications in the future, so we do refer to cardiology rather quickly. Pulmonary also, we've been kind of really hand-stepped in with our colleagues in the pulmonary department here at Queen's. Neuropsych, also the neuroscience center here at Queen's has been quite accommodating for patients when we send up, but also for the Hawaii Pacific Neuroscience Center, they've also been gracious in seeing our patients with long COVID. And so there are some consideration that cog rehab may be helpful. I provide patients with just website that they could actually look at, like Luminosity, or even less so of some tools that they could use to just engage their brain. Whether or not cog rehab truly works it's another discussion that we could have. I know someone had mentioned, do we have cardiac do we have pulmonary rehab? And we don't right now. We do tell people to try to exercise, try not to go beyond 80% of the maximal heart rate, to take deep breaths, which I'm going to talk about in a little bit. And then even for cardiology, cardiac rehab has been a little challenging, but we've been sending our patients to just Queens rehab, and we've been working with them in terms of trying to get people back into at least some form of exercise for working, to do on a daily basis. And we do get patients in to see the subspecialist much more quickly. And I think we coordinate with PT and OT quicker than I think on the outside. Next slide. And so I think looking at treatment, and it's evolving every day. Every day you may actually hear about newer therapies that might be involved. And I could say that there's been a lot of discussion about certain clinical trials, but none have actually been shown, primarily because I think long COVID is really heterogeneous. It's not homogeneous in its presentation. Some will have brain fog and no cardiac, some will have cardiac and respiratory, and some will have some anxiety issues. So no one person is there a typical long COVID patient. And so you could see that a lot of people will have chronic fatigue, but not everybody. I think by far getting vaccinated with the COVID vaccine has been shown in multiple studies that it has been helpful. I could say that in people who come for long COVID, I give them the COVID vaccination. I would say a quarter of all the people who were unvaccinated, who got vaccinated, they feel much better. And I'm not sure if it's, I'm fooling myself or patients are, maybe feeling placebo effect, but it seems to be helping our patients. So do promote vaccinations. Heart rate I mentioned, we don't want to go beyond 80%, primarily because a lot of these patients may have the POTS or the post-COVID tachycardia syndrome, and that may actually make them feel worse if you try to overexhaust them. Improving sleep is important, taking SSRIs, SNRIs, counseling, and then this whole issue of aspirin, antiplatelet, and statin therapy has been touted as being potentially reducing overall monocyte activation and maybe reducing viral transcripts too. And there's, maybe also microclots gets into this whole mix also. But our patients, as you know, I started off by saying our long COVID patients are at higher risk for cardiac outcomes. You would probably want to start patients on a statin and maybe aspirin in a much lower threshold compared to your general patients. And I think that maybe because this long COVID may have permanently affected the immunologic system, that they may be at higher risk for thrombotic events in the future. And so I know aspirin is controversial. We previously don't want it as a primary prevention, but perhaps patients who have had COVID infections may be at a higher risk of coronary disease, may be candidates for aspirin therapy. Unclear use, the hydroxychloroquine has not been shown to be of any benefit to acute COVID, and I don't think in long COVID. Ivermectin, there were initial reports that it may be helpful for long COVID, but there was a beautiful article in the New England Journal of Medicine that kind of disputed of how ivermectin was initially used, and then some of the data that was from third world countries were kind of flawed, and hence it didn't show a signal. And even one of the main authors for the ivermectin study that I think it was a meta-analysis even went about disclaiming his own study because one of the studies was flawed. And so I applaud you to look into the ivermectin data before treating patients with it. Maraviroc, which is a HIV medications, works on CCR5. It has been also interested in using it in terms of long COVID. I think there is a clinical trial that's waiting for its final results. And then some clinicians have actually given iodine, high doses of vitamin D, E, and E. And one practitioner had even had patients drink hydrogen peroxide. I don't advocate that. I think the iodine, high vitamin D and E can lead to some toxicity. So in right now, there haven't been any good studies that show that it works. So not to use that. Next slide. Exercise, deep breathing seems to be a improvement for pulmonary disease. And oxygen supplementation, obviously, if the patient has low oxygenation. ICS and lambda, actually, there was a study that was called the Principal Trial. They used it for acute COVID, but they extended it for after the patient had gotten better. And they did see that there were less cases of long COVID. And so I've been more or less pushing for ICS and LABA in terms of our patients. So like Symbicort or Advair for people who have pulmonary respiratory symptoms, it seems to help them, even though that sometimes the PFTs doesn't come back showing a obstructive lung disease. They seem to get some improvements. And I think it is also because of some of the mast cell activations, which I'm going to get into the next slide. There are some herbal supplements. There is even something called Toxic Lid that is a antiviral. I'm going to talk about it in the next slide. Use of oral steroids is unclear. I think you should be a little bit careful. I would do the inhaled, but not the oral, as some patients can have a real trouble getting off of these oral steroids. And then ACE and ARB, I think in my next slide, shows that the next slide shows that it shows some improvement. Oh, so the next slide. So we have our own study here at Hawaii looking at acute COVID, but there seems to be also some reports that people with on ARBs and ACE have less long COVID in the future. And it makes sense if you're going to block the ACE2 receptor or the angiotensin-renin system, perhaps this can actually offer some overall protection to your patients. Next slide. So lots of patients have cough, and I think that's the primary thing that oftentimes I get a pat on the back, because our patients will come to us and they'll be coughing continuously and can't get any sleep. And I look like a real hero by actually telling them to take lots of antihistamine and maybe even H2 blocker. And so I think what a lot of people don't know is mast cell activation can be quite strong, and then you need lots of antihistamine. So if you were to come to our post-COVID care clinic, you'll see me prescribe Zyrtec up to 40 milligrams a day, so 4 tablets a day, and rather than just 1 tablet generally for the adult population. And people will say, wow, that's a lot of antihistamine. And by the 3rd or 4th day, when I call them, they'll say, Doc, you're wonderful. I stopped coughing. I'm able to sleep. I sleep very well. And that in itself helps them clear their minds a little bit, and they have less brain fog. I don't know if it's these mast cell activations that may be causing some of the issues in the brain, but clearly, if I could help them stop their cough, stop the insomnia, they actually do get better. So again, a really high dose of antihistamine is required for these patients. And I think once you stabilize these mast cells, you probably give it for a couple months, and then probably likely that you could just remove it after maybe 3 or 4 months. Next slide. The brain fog, COG rehab, reminder, supportive therapy is very important. Antiplatelet therapy is kind of what I often will start patients on. Seems to help some of our clients initially. And then the Stimulate trial, as I mentioned, is still in peer review, and it hasn't gone through in the past 3 weeks. And I'm wondering if people are a little bit concerned about what, because there were no controls in the Stimulate. So this is a UK trial looking at apixaban, aspirin, and Plavix, all combined together. So dual antiplatelet therapy, and then 1 NOAC was what these individuals with brain fog took. And they found that these individuals, almost all of the 40 individuals, improved in terms of fatigue. And so I don't want to suggest that that's a therapy that we want to entertain, but it's interesting as a concept. And I wish that they had placebo control so that we could see really, is it a placebo effect or is it really real? I do believe that probably antiplatelet therapy is warranted. I'm not sure about NOACs, but and I don't know how long they're going to do it for, but we'll see. There's this whole issue of anxiety, counseling, benzodiazepines, medical marijuana. Some people said CBD seems to help. Again, these are all small trials that seem to have some effects on patients. Next slide. And then POTS, now it's called post-COVID tachycardia syndrome, exercise or recumbent bike, oral rehydration, increasing salt intake. I suggest up to 6 grams of salt a day. Many of you know that you probably consume only 3 to 4 grams. The Japanese probably consume 9 grams of salt a day. So it's okay to push the salt, primarily because if you could get rid of the dizziness, restore some of the effects so that they could exercise, it gets you there. I have prescribed my fair share of midodrine, beta blockers, and mineralocorticoids, and none of those seem to affect our patients. I've also given some colchicine, also not seeming to affect our patients at all, or at least a small handful of patients I've had. And then endotheliitis, these thromboevents, these NOACs, aspirin, I basically continue them on if they've been in the hospital for at least 6 months, but then I often stop it. I don't continue patients on, and I don't start people on NOACs for long COVID. And then you may have seen in the newspaper this apheresis, it's a plasma exchange. They get these patients in. It's very, it's been, I think the Germans are the ones who are really spearheading this. They'll hook these patients up to a plasmapheresis machine. They'll spin out and they'll get clots. But my feeling is that you haven't changed the mechanism of why these patients have clots. And so therefore, I'm not sure if the apheresis would actually work long-term for these patients. But they are getting clots off these machines, and they are saying that there's micro clots in these patients. Next slide. And then loss of taste and smell. We've been, I've been telling people about the University of Ohio trial on COG rehab. They send you essential oils and foods. They'll mail it to you. I always tell people, if you know a food taste, they'll suck on it, and then they'll kind of try to rehab the brain. This is a lemon, this is a lemon, this is a lemon. So you're retraining your brain because you've had disruption in the brain. And lots of people have funny taste, and you have to gain back that whole original sense of taste and smell, and it's going to take a while. I've used some Flonase, I've used some Dymista, seems not to work as well, but I think the COG rehab in some of our patients who are truly committed to rehab has worked for our patients. Next slide. And so remedies not recommended, ginkgoba, because sometimes it could cause arrhythmias, ginseng, garlic, because of some effects. And so these are some things that have been said to be a no-no in terms of long COVID. Next slide. Potential therapies in the future. Paxlovid is something that we've been giving in the hospital. I know at Queens and HPH. I've been trying to figure out when it would be more available, and then maybe providing it to our patients, because then we could attack the virus that way. And then, Merck has its own drug. It hasn't been as well received. And then if you were to Google Tolavid, and it's a herbal protease inhibitor, you'll see that they say they have people testimonials say that it helps them with long COVID. And I'm not sure about it, but it is a natural occurring protease inhibitor. Problem is, for people who have worked in HIV, protease inhibitors have very low serum concentration, and you need something to boost it. And so even for the Pfizer drug, you have to take ritonavir in order to boost those levels in an intracellular level in order for it to work. So I'm not sure if it would work. If you took a lot of it, maybe. I'm not sure how it would be. Mast cell inhibitors, we've been looking at that. Our group has also been looking at mast cell inhibitors as a possible way of helping with long COVID. Inhaled temosartan has gotten some also traction. Stem cell therapy, if you Google Hope Bioscience Center, they're willing to even send out people who have long COVID and brain fog to Texas, Houston, and get stem cell therapy. I'm not sure how how robust the data is. And then the hyperbaric oxygen therapy has been also reported as being a possibility. And I've seen some data seems to help some people. Again, I'm not sure, there's no control with it, so I'm not sure how to advise our patients, but I'm all for trying for our patients who have no other alternative. Next slide. And so, again, most of the treatment, I think, for COVID should always be prevention. Coming from a school of public health, I think prevention, vaccine, social public distancing and public health is very important. But if not, if your patient has gotten COVID, I would always tell you to call. I know HPH has their own line. Queens has this transitional case management program. You could call that number, usually, unfortunately, under a weekday, and they could actually either give you a infusion of the monoclonal antibody or I know that they have Paxlovid antivirals available for people to. Unfortunately, if the patient continues to require hospitalization, there'll be a hospitals team, critical care, and then we see our patients mainly at the post-COVID care clinic at Queens. We don't see it at I know a lot of people know I'm from the Spencer Clinic. We don't see post-COVID care patients there. It's mainly at Queens that we have our post-COVID care clinic. And in research, obviously, we want to know and try to see what is the true incidence of long COVID. Next slide. This is our referral form. Unfortunately, we restricted to mainly commercial, not Kaiser. And then, you guys could click on and we asked you some questions as far as trying to help us define whether or not this patient is our appropriate patient to be referred to our clinic. We are running about 4 to 8 weeks out for the first visit. Next slide. And then you can see some of our people here, our clinic, Dr. Fritz Igno, who's our champion at our post-COVID care clinic. And then other clinicians, Dr. Yes, Dr. Bello, and Dr. Gerardo Kaka, are individuals who also see patients at the post-COVID care clinic. And the next slide. I just wanted to do a brief mention about the Recover. It is researching COVID to enhance recovery. As I mentioned, there is a large number of individuals who may be inflicted with long COVID, and so we need to study this better. So next slide. And so I ask you, if you have patients who have recently been infected with COVID, or even not recently infected with COVID, if you could help us by having them kind of call the number 723-0040. And it's a Japson study. We are hooked up with Japson, but with Queens, but it also will be open to HPH. There's no reason why we need to just keep it at Queens, but at Japson, we are trying to recruit and be part of this 17,000 person study trial that will really look at long COVID and its effects. And it not only is going to be helpful for long COVID, but kind of like the Honolulu Heart, Honolulu Heart morphed into more like a neurologic and aging study. This study is going to recruit not only people who have long COVID, who have recovered from COVID, but also negative patients. So any one of you can actually participate in this trial as we learn more about long COVID, but it's likely it's going to also morph into a large longitudinal study of general health, the population, kind of like the aging trials that the NIH trials do on aging. Again, if you have any questions, you could call me. For patients who have long COVID, and you're wondering, so what does this trial do? And it may be different from our long COVID clinic. Well, this trial is going to look at them longitudinally through time and also put them at different tiers. So they could do like brain imaging for even people who are asymptomatic. They could also do tilt table. I think that's been a desire of a lot of our patients who have dizziness. They do get a tilt table test. We don't normally do that here at our clinic. and kind of quantitating the POTS or the post-COVID tachycardial syndrome. And so there's lots of things like pulmonary function tests and looking at immunologic profiles of these patients. And so let me know if you have any troubles, but we do want to participate in this large NIH trial. Next slide. And I think that's it. So I can entertain any questions you have. I did try to answer some of the questions. The chat did go by quickly, so I wasn't sure if there's any other questions I might have missed.
Dominic, thank you so much for an excellent presentation. Yes, we do have a couple of questions. So one is from Dr. Okamoto, who says she has patients who never tested positive, but who were on nursing home floors with major outbreaks. Some are exhibiting long COVID symptoms, but she doesn't have a documented positive test result. How would you approach these patients?
Yeah, so as we get more into home kits and such, our clinic is even open to, so kind of like people saying, I had a home positive test. They just have to go to the PCP and the PCP will refer. And we do that antibody testing. So if, I know antibody testing isn't, universal as far as, it's not consistently high, but if you've suspected that your patient has long COVID, I would immediately get a antibody test. Recall that there's antibodies to 5, spike protein, nucleic acid in the varying sites, but I think Queens at least does the spike protein and the nucleic acid one. So I might have misspoken. The nucleic acid is the one that we typically draw because that's the one of natural infection. Because the spike protein is the one that all of us would probably develop after the antibody, of getting the vaccination. And so once you've gotten that diagnosis, then it's hard because I know patients are hard to move off the floor, and we don't have patients going over to nursing homes. So I don't know how, if they're part of HPH, I know Bennett Louis does a telehealth one with them. Cardiology would be obviously, and pulmonary would be the next things of trying to see, because I think a lot of those patients would probably exhibit cardiac postural, fatigue and issues, and probably the pulmonologist and the cardiologist would be the ones who would probably be the most helpful.
Thank you, Dominic. Are there any other questions? I know Dr. Yamada's question was already answered, that Clint Spencer Clinic is not seeing long COVID patients, but they're being seen at the Queen Anne Clinic. Any other questions for Dr. Chow, since we have him here?
If I could just say, hydration is so important. So maybe for your patients to kind of consider hydration. And I don't know how to do that rehab of trying to do daily exercise. I think if you were to see the ones who, I see my patients, the ones who are not doing so well, the ones who are kind of flatline in terms of progression, the ones who really do well, it's often the ones who actually take it to heart about exercising and really pushing it and taking deep breaths. And so I have one patient who really is fantastic. He had, even as in the ICU, he had, if you looked at his CT scan, it looked like Swiss cheese. And his wife is a physical therapist and really got on him and really got him to do physical therapy. And in amount of time, he got better and better and better every time. And that he, his lungs CT scan almost looks normal, but some manifestations still a problem. But he is our poster boy, so to speak. He was using oxygen, wheelchair bound, and now he's walking. He's doing Magic Island. He does almost an hour of exercise every day. And so exercise and hydration, I can't say enough about it.
Wonderful. Any other
Dominic,
questions?
Dominic, Seiji Yamada here. Hi. I assume you can get post-COVID even after you've been vaccinated, and I suppose it's given that we have different waves of different variants, it's kind of hard to say, but should we still think of vaccinations protecting us against long COVID? And would manifestations of long COVID be any different with, say, the different variants that we've been experiencing?
Yeah, so we've been seeing more recently people who have had 1 or 2 shots of the COVID vaccinations and are coming in still to the clinic. So overall, there is people who are vaccinated, and 7% of patients are already dual vaccinated, and we're still seeing patients. And so my overall feeling, you probably see in your general practice, people are still coming in with COVID infections. So the symptoms are not as severe as the ones before, but it's hard to tell because the ones that were in a clinic that started in the initial part of the epidemic were really all the people who are down from the ICU. So we don't see as many people down from the ICU as before, but wow, when we first started our post-COVID care clinic, I think almost 100% of people were post-hospitalization. And so perhaps I'm thinking that maybe it's less severe, but a lot more brain fog in our recent wave of people. And it'll be important to get these people in to do some type of blood testing research, I think, because immunologically, they're probably different from you and me, right? Because if you got it, perhaps they have some reason for why they're getting long COVID. So it'd be good to figure that out in the future. Would I give the booster? Absolutely. I would tell people to boost them as much as possible. Vivek Nurikar, who's tropical medicine, he would say that the peaks and spikes of the COVID immunologic does very well with boosting. And so he always says about how we protect ourselves more and more with each vaccination, and that how fast viruses replicate has actually or much lower in people who are vaccinated. So for that reason, maybe the virologic peak will be much less.
But to some extent, the incidence of long COVID does also happen in patients with mild infections too, right? And
Yep.
I think we've also seen a few patients that seem to have developed diabetes. I don't suppose we've screened them very well for diabetes beforehand, but they seem to have developed diabetes post-COVID.
Yeah, you bring that up. I mean, all these things possibly maybe have occurred even before COVID. We're not sure, but clearly maybe COVID has made it worse. And what are we seeing? Are we seeing manifestations of early aging, or is it from COVID? It's hard to tell. I mean, that's why I think reaching out to each of the departments, because you guys do so well with looking at frailty and looking at neurologic, I think we have to work together to try to figure out what are the, you guys do so well with certain things in terms of looking at studies and figuring out what are the kind of, any department, it's probably geriatrics that has probably the most experience with cognitive assessment. It's hard. Some of our youngest patients, as you mentioned, are having, brain fog, and yeah, they don't score so well on the MOCA. They score like a 24, 25, and that's sad. That's gonna be profound in future wise.
I know, Dominic, I've seen data about people have been speculating about what this will do to rates of Alzheimer's disease and other chronic diseases down the road as well.
Yeah. So it's going to be a big disability issue. So I think I worry for our country as well as healthcare, because we don't have that many specialists, and there is a shortage of primary any clinician. So it may stress the healthcare system some more down the road.
Dominic, thank you so much. Very informative. Thank you for staying to answer the questions. And thank you, ladies and gentlemen, for your attention.
Thank
Hope
you,
to
guys.
see you again next month. Okay, bye-bye.
Bye-bye.
Please don't forget to fill out your evaluation for your CME credits. Okay, thank you. Thank you again, Dominic. Bye-bye.